Hello, and welcome to session 4 of 6 of the Improving Implementation Learning Module series. This session focuses on implementing environmental modification in the Comprehensive Behaviour Support Plan. Our rationale for this session is that PBS practice recognises that significant behaviour change and reduction of risk occurs when the environment effectively meets the need of the participant. Implementing environmental change involves stakeholder management, resourcing, and time planning to be effective. And our objective is that learners will understand the planning approaches for environmental modification, noting the requirements for working with others. So, just a recap of what constitutes a participant environment. We often reductively consider a participant environment to simply be the home in which they live. However, if we look at this graphic, we can see that the environments can be stretched out into that immediately involving the participant, the home environment for the person, noting that there may be multiple homes, the community environment, and the clinical environment in which the person lives. And a behaviour support plan involves modification, addition, removal, or co working of any of these environmental aspects, including the work of key formal and informal supports. So, any adjustment to any aspects of this environment require collaboration and buy in from each of the stakeholders and appropriate funding resources to facilitate the change, noting that this funding is not just based on behaviour support funding, but can also be based on core and NDIS funding. I encourage you to consider this particular graphic heavily when planning the implementation for the person and when planning the preparation of the behaviour support plan, because determining what each of these environments should look like for the person based on their identified needs, remembering to keep our person at the centre, keep their consultation at the centre, will actually give a significant indication to what changes need to be made to reduce behaviours of risk. We know that a conducive environment reduces behaviours of risk significantly. So when we start to think about modifying the environment, ensure that our behaviour support plan correctly identifies what the current environment looks like and what it needs to look like to support the person. Look at the sections about consultation and other sources of information. Look at what the experts in other areas have said, speech pathologists, occupational therapists. Look at what supports are saying about the person's response to their environment. Talk to the person and their supports intensely about what they're looking for in terms of aspiration. Look at your proactive and response strategies. Remember that environmental change is usually the key aspect or the beginning catalyst for a lot of other aspects of implementation. And if you notice many of the other sessions in this series, you will see that the environmental modification often comes first, and then that instigates the direction for data collection, for reporting, and for restrictive practices fade out. So, some key modification considerations as we begin the implementation phase. First of all, we must ensure the person is at the centre of the modification. Plan for consultation, plan for choice and control in implementation, and ensure the person is at the centre of understanding and giving choice and control about what those changes look like. For example, a person transitioning into supported accommodation should have significant opportunity to contribute to what that looks like, what their space looks like, the people that they, or the amount of people that they live with, what their supports can look like. We need to ensure that the person is at the centre of that process. We are creating and supporting a home for that person. If we're talking about employment aspirations, for example, have the person at the centre of those discussions and allow them to lead the planning of this. Look at creating your team. We know throughout all of these sessions for implementation, the team-based approach in terms of clinicians, but also in terms of allied health, key stakeholders, daily supports, family. We know that we have to create, communicate, and collaborate because there's no one part of behaviour support that simply occurs from the behaviour support practitioner. Look at plans and deliverable dates. Many of these are structured and set in stone, so things like the NDIS plan dates, but think about the fact that environmental modifications depend on other funding. So core funding capacity building funding. So be aware of how these are likely to impact on your behaviour support plan implementation. There are going to be barriers to implementing any environmental modification in the BSP. And I encourage you to look at the micro learning that talks specifically about facing and mitigating barriers to BSP implementation. If you can't adjust, communicate the barriers that you're facing and report it so that funding isn't lost on going round and round in circles with no deliverable outcome, and ensure that that can be reported to the Commission if it transpires that your BSP budget becomes exhausted before you can achieve your obligations. And then make sure you understand the individual tasks. Look at the implementation spreadsheet and consider that each task list is going to be unique to the person. Know all the tasks, know all that they involve in order to achieve them. I've taken an excerpt from the implementation spreadsheet here, just focusing on the key environmental and modification and deliverables. So you can't see the other aspects to do with reporting or communicating care teams, etc. However, when we look at these subtasks, we can connect this to our reporting, our care team meeting participant agreed deliverables. We look at our subtask. Our subtask here is about transitioning into a SIL, and we would need to use our care team to understand and support what that would look like in terms of timeframes. We need to make sure we communicate the subtasks for co-scheduling. I've talked about using allied health implementation timelines before, but I think it's particularly important also when we're doing significant environmental modifications, because these will occur around us. We can't necessarily control those. Consider how each of the tasks I've put here look different for each participant. The items put into this particular implementation spreadsheet are a guide only, and there may be additional tasks that are not included here. So modify your implementation spreadsheet carefully to meet the needs of the individual person. Recognise that overruns and delays are inevitable. One of the questions often given about implementation plans is, what if it has to change? And the answer is, it's almost inevitably going to change. It's a plan, it's not a contract, but it's an opportunity to identify how we're going to approach this, recognising that changes and overruns are part of the process. In terms of timelines and budgets, it can be ideal to communicate your budget and timeframes to stakeholders, and it can help bring them aboard. You may even go into the stakeholder meeting with the implementation planning spreadsheet and attempt to set up co-dates that fit with all aspects of that implementation together. For example, we talked earlier about SIL-based transition or supported accommodation transition. So you may need to liaise with support coordinators, with SIL providers, with planners. You may need to liaise with the supports and the staff within that space, with the family of the person who's transitioning, the person themselves, obviously. You could set that planning out together prior to publication of the behaviour support plan, and then you have a really clear understanding of what that has to look like. Implementation budgets need to take into account planning meetings, monitoring, data collection, and reporting for implemented strategies. And if you watch the other particular sessions in this series, you will see that I often talk about environmental modification as being the key instigator of a lot of the other aspects of implementation that occur. So no one aspect occurs in a vacuum or in isolation. Each aspect of implementation needs to be co-planned, and that's why we have an implementation spreadsheet to allow you to consider those aspects together. Be really realistic about your set timelines. Set your key deliverable stages so they work towards a bigger environmental change or behaviour support goal. And I encourage you to watch the micro learning that talks about conceptualizing and designing implementation. So the proficient micro learning on designing implementation talks about how we actually set up a key behaviour support goal and then understand the environmental modification subtasks that fall underneath that. And if you view that particular micro learning and then come back and perhaps rewatch this and go into your spreadsheet, you're going to find that it's easy to conceptualize that big picture thinking that then drips down to the subtasks of environmental modification. Remember that any modifications involve recognising and liaising with timelines and budgets of other stakeholders, and be prepared to weather the delays that are part of that. Next steps for the clinician in planning your environmental modifications. First of all, when we are developing our behaviour support plan, have we placed our participant at the centre? Are the modifications we're intending to make conducive with an enabling environment for the person? Do they help the person to increase their quality of life? Do the environmental modifications reduce the likelihood of risk? Do they increase choice and control? And are they likely to work towards fading out restrictive practices? What does a stakeholder team need to make it function? Particularly for beginning clinicians and early careers clinicians, it can be incredibly daunting to be asked to chair or manage a stakeholder team. Seek your clinical advice on this, seek your support. If you need additional clinician oversight, ask for that and make arrangements in the implementation plan for co-clinician support. Some implementations, some environmental modifications can be extremely complicated. So it's important to use your clinical resources there rather than just chewing through funding, attempting to nut it out by yourself. Second, look at your subtasks. Be really clear of the aspects of the environment you intend to modify. And go back to the graphic showed at the beginning of this session to consider which aspects of the environment are we modifying and when are these going to be taking place. Noting that we have to time in other aspects of our implementation to fit, things like training, for example. Consider the behaviour support plans that are already in place. Consider other plans that are already in place. Where do they fit with this particular environmental modification? So, are there other environmental modifications planned by other supports in place? Occupational therapists with assistive technologies, for example, speech pathology with communication supports. And then visualize. Map out your changes for the person across the BSP lifespan. Remember to keep your goals SMART, specific, measurable, achievable, realistic, and time bound, so that we're not aiming for an enormous goal in a 12-month period. We need significant goals, but that does not necessarily mean that they are enormous goals. And it's important to recognize what is absolutely attainable within that 12-month period. And then think, what does this mean for behaviour support? Where do I fit in with this larger system? The resource microlearnings support a number of aspects of environmental modification and recognising what these look like. So, considering restrictive practices fade out, considering designing our implementation, and considering managing our barriers from the proficient capability learning library, probably really valuable in supporting this particular aspect of your understanding. I encourage you to use all aspects of the microlearning library in conjunction with this presentation, as well as the induction or foundation module series, which is available to all clinicians within the organisation. Good luck.